Yes, doctor, start please.
Yeah. Hello.
Hello.
Hello, Mr. Lara. This is Dr. Ambati, one of the
Yes.
doctors working here today.
Yeah,
We are here
doctor.
to talk about your medical condition. Is that okay?
Yes, doctor.
Yeah, I can see that from the note that you've been having some leg swelling. Can you tell
Yeah,
me more
doctor.
about that?
Really, doctor, I have been suffering this is swelling in my legs and pain also since 3 days, doctor.
Okay. Since 3 days.
Yeah.
Have you had this swelling before?
No, no, this first time, doctor.
Bef- First time. Okay. Can I see the swelling, please?
Yeah, doctor, see this one.
Okay. Are you sharing on the screen, doctor? Okay.
Yeah.
Okay. Right. Is it painful, Mr. Lara?
Yeah, doctor, it's painful, yes.
Okay. And did it start all of a sudden?
Yeah, it starts suddenly, doctor, but really increase.
Oh, is it increasing? Okay, I'm sorry
Yeah,
to
yeah,
hear that.
yeah.
Okay. And on a scale of 1 to 10, how much would you rate this pain?
Doctor, about 6 to 7.
And can you describe the pain for me, please? How is
It
it?
looks,
Is sharp
it
or
looks
dull
sharp,
or
yes. Sharp, sharp pain, doctor.
sharp pain? And is it radiating to somewhere else?
No, doctor, only my leg.
Only in your leg. And have you noticed anything that is increasing it?
No, no, nothing specific, doctor.
And anything decreasing?
Yeah, rest, rest. If I rest it, I feel better.
Okay. Are you having any fever?
No, doctor, you mean body temperature, rest body
Yeah.
temperature.
Any
No,
high body temperature? No.
no,
No.
doctor.
Okay. Okay. Are you having any shortness of breath?
No, doctor.
Any chest pain?
No,
Any racing of your heartbeats?
no, doctor.
Any cough?
No,
Any phlegm?
no,
Any coughing up blood?
no,
Okay. Do you have any lumps or bumps in your body?
no, doctor.
Do you feel tired?
No.
Okay. So, can I examine you, Mr. Lara?
Yes, doctor, examine.
I would like to look at the pulse.
Pulse, regular, 80 beats per minute, and
Okay.
normal character.
I would like to see for any JVP.
GVP normal, not
I would
raised.
like to auscultate the chest,
Examination of the chest normal,
auscultate the for heart sounds.
normal,
I would like to look at the both the legs,
yeah.
the size of the circumference of the legs
How can measure the difference between the
with the
legs?
tape, with the
Yeah,
tape.
what the side of measurements?
Both, both the sides, both the legs.
Yeah, where exactly? You tell me here in picture where you will
At
put this
the calf,
measure.
at the calf,
Okay,
at the
type.
calf.
Okay,
Yeah.
okay. There's
So I
difference.
can see that there is an increased circumference in the right leg.
Yes,
Okay, I will just see if it is warm.
it's not. It's warm. Yes, it's warm.
It's warm, and is it tender to touch?
Yeah,
Is it painful?
yeah, painful.
And yeah, I would like to lift the leg and press on the calf.
Yes,
So is that painful?
yeah, it's painful.
Okay, right. Okay. So, Mrs. Lara, Mr. Lara, thank you for letting me examine you. Do you have
Thank
any
you.
past medical history I need to be aware of?
No, doctor, nothing before.
Okay. And are you on any medications at the moment?
No, doctor.
Okay. Do you have any allergies?
No.
Have you recently traveled anywhere?
Yeah, doctor. I was in Malaysia. I returned back 1 week before.
Okay. I'm okay. And did you take any long flight?
Yeah, it was long, doctor.
Okay. When did you return back?
1 week before.
1 week before. And have you been mobilizing since then, or have you been on the bed
Yeah.
or taking rest?
No, no, doctor. I am moving.
Okay. Have you had, and you never had this kind of episodes before?
No, no, this first time.
Okay. And any family history of significant, many blood clots in the family?
Yes, doctor, my mother has lung clot when she was 40 years.
Okay. Okay. And do you know what she was diagnosed with?
No, no, doctor, they told that this lung clot and she's on warfarin until now. Medication is called warfarin.
All right. Okay. Right. And do you smoke, Mr. Lara?
Yes, doctor, I'm smoking
How many cigarettes do you smoke?
10 cigarettes,
And since how long?
5 years,
Okay. And do you drink alcohol?
only on weekend, doctor.
Right. And I'm sorry to ask you, I ask this question to all of my patients.
Yeah,
Do
doctor.
you take any illicit drugs?
No, no, doctor.
Okay. Right. So, Mr. Lara, can I know what's your concern?
What I have, doctor?
Mr. Lara, uh, from the conversation we had today, I think you are having a condition called thrombosis. It's a deep vein thrombosis.
Yeah.
Okay. It occurs when someone travels for a long distance. Okay. Like you have traveled to Malaysia.
Yeah, but this not
So,
first time, doctor. I am traveling to long, longer travel.
right. So, we can't tell you what could be the reason you had this time,
Yeah.
but definitely this is one of the possibility that you had probably you had this clot in your one of your legs because of the long travel,
Yes.
and also your mother has a similar condition, so the probability of you having this kind of clots is significantly higher than the normal population.
Oh.
Okay.
Yeah. Okay, doctor. Yes.
So what I want to do now
Yes.
is um, I will want to do again a complete examination
Yes.
after this, okay, and we'll do some basic investigations in the form of blood investigations.
Yes.
We would like to look at the blood vessels in your legs also by a jelly scan to
Yes.
see if any one of the blood channels have been blocked. And since you are having this painful, we will also give you some painkillers for that,
Yeah. Thank you, doctor.
and also some blood thinning medications. As you said, your mother has been taking warfarin,
Yeah.
right? Okay,
So,
so
doctor, I should stay in hospital.
yeah, and there's another thing. So what happens is this clot can travel through your blood channels
Yeah.
and also can dislodge into your lungs and
Yes.
can sometimes can cause fatal accidents, and you might lose your life. Okay,
Time. Time, doctor.
okay,
Doctor Ampati,
yeah,
you spent about 2 minutes, 2 minutes answering concerns and explain the disease.
yeah.
In the exam, how can find 2 minutes in the station 5 to explain? So there is something forgetting this in this case. So for that reason, you find more time.
Okay.
So how do you feel with yourself in this case? Tell me uh, about your performance before to tell you. How do you feel yourself?
Mm, I think I should have done the system review much more.
I mean, are you satisfied about your performance now?
Pardon me?
Yeah, yeah. Are you satisfied? Are you satisfied about your performance
Are you
now?
what?
Satisfied, satisfied.
Satisfied? Okay.
Yeah,
Uh, I should have done the system review much better,
yeah. Why?
and
Why?
because I don't rule out the other conditions.
Yeah. What the underlying cause? I mean, in this case, it's a clear DVT from outside. Is
Right.
it right? So please don't take me anything personally. We are here to teach only
Yeah,
and
yeah, yeah.
improve our performance. So you see the case from outside. It's clear that this case most likely DVT.
Hmm.
Okay. And when you see the legs and the patient tell you that I have swelling, painful swelling in the legs, and you see the legs, so you know that this is DVT. No, now this is very easy for any one of us to know that this DVT. But where's the problem? The problem to know what the underlying cause of DVT, and this is what's important in the exam. It's not necessary. here, if you tell the examiner this patient has DVT, he will tell you, doctor, any medical student can tell me that this DVT, but I need from you as senior house officer to tell me why this patient has DVT. If you tell him she was traveling, he will tell you, okay, this is one of the provoking factors of DVT, but you don't. The examiner didn't notice you that asking about the other cause, common cause of DVT. We have common causes of DVT, as we know. So my question for you now,
Yeah.
what are common causes of VT at all, venous
Uh,
thrombosis?
any drugs like OCPs,
Yeah.
malignancy.
So you do you ask about OCP?
The patient is Mr. Right? Mr. Lara?
Mrs. Lara.
Oh my God. I have written, sorry, I have written it as Mr. Lara, so I didn't ask the female and the
Okay, no
OCP.
problem. Type, okay. Uh,
Okay.
so this is maybe this maybe
I'm
change
sorry
the
because I have written as Mr. Lara.
no problem. Type, the other causes of VT.
So it could be Behçet's disease or any autoimmune conditions,
Yeah,
AMPLA, SLE.
Behçet disease. Do you ask me about the symptoms of Behçet disease?
No, I should have asked any oral ulcers, genital ulcers,
What else?
and painful oral ulcers and genital ulcers, and any rash.
Yeah, what else? What other disease can cause VT?
SLE can cause.
SLE. Do you ask me about joint pain, about skin rash?
No, no, no.
What else?
And APLA, any previous abortions, antiphospholipid antibody
Yeah.
syndrome.
Okay, because you suppose that's male, maybe we forget. Okay, what else?
Mm,
This is a common case. This is a common in our life also, real life. Inflammatory bowel disease. In inflammatory
okay.
bowel disease, we know that Crohn disease, especially Crohn disease, can cause VT. So you should ask about change in bowel habits, blood emotion. This is very important. Also, polycythemia. Polycythemia.
Okay,
Also, it
okay.
came before in exam many times, polycythemia, but usually polycythemia will cause atypical DVT in other sites, like most likely will cause pulmonary embolism, cerebral venous thrombosis, or in the upper limbs. But you should ask any patients polycythemia. Also, what else? This is also came before in the exam. Nocturnal,
PNH, paroxysmal nocturnal hemoglobinuria.
paroxysmal nocturnal
Hemoglobinuria.
hemoglobinuria. So this also you should ask about this. And
Yeah,
we have also recent surgery. Maybe the patient now she has
yeah.
he has recent surgery. Also, this is very important to know. So this case really it's simple case. It's not difficult case, and very
Oh,
common in the exam situation. Really very common in the exam situation. Anyone take exam before know that this is very common in the exam situation. But where the problem that because it's simple case, many candidates lost this case because they don't concentrate well in the case. They consider their self their performance is good because they know now this DVT. Now I get this DVT. I ask the patient about pulmonary embolism, and now I'm good. So this is the most important thing in this scenario to know what's the underlying cause. So this scenario we have three important tasks. First of all, to confirm that this DVT, nothing else. Then to rule out pulmonary embolism, and thank you for that because you should rule out pulmonary embolism and not enough to ask about chest pain, shortness of breath. You should ask about also palpitation, cough, and cough up blood. Very important, okay? And
okay.
then you should know what's the underlying cause. Inshallah, I will try to explain in details. So, what's your diagnosis, Dr. Ampati?
So, deep vein thrombosis secondary to
Yeah.
travel history.
This patient, طبعا, if you ask me, she has because you forget because you consider her male, so you don't
Yeah.
ask about periods. This patient she has two abortions before, so most likely this patient she has antiphospholipid antibodies syndrome. Okay,
Okay.
investigation. What you will do for any patient now present with suspicion of DVT,
I
like
would
this.
like to I would like to do an chest X-ray.
Yeah,
I would like to do an ultrasound Doppler studies of the lower limb.
yeah.
And if suspicion is high, then I would like to start on a warfarin and proceed with the Doppler studies.
Okay. My question: you will do the Doppler
Yeah.
ultrasound for all people present to you with leg swelling?
If the cause is very evident, like in this case, then you can directly start on the treatment.
Yeah, I mean, you will investigate all patient with leg, not our patient. The question is general. You will do ultrasound for all patient has leg swelling, or there's you
Yes,
have any scales can guide you to do or
well
not do.
score. I could do a well score,
Two level well scores. Yes, you are
two
right.
level well score.
This is very important. This is to estimate the probability of DVT based on clinical assessment, either history and examination, history
Yeah.
and examination. So usually this is the one. It's not necessary to know all points for this score, but at least you should know it in your mind. You should ask it. Do you have any idea about this score?
Yeah. Age more than 65.
No,
Uh,
no age, no age.
no, I think swelling. I'm not sure. I just forgot. I don't remember.
Okay, I will remind you
Okay.
fast. You will give the score one point for each one. Active cancer,
Okay.
paralysis. So 1 point for active cancer,
Okay.
paralysis or paresis or recent plaster embolization of lower extremity,
Okay.
recently bedridden for 3 days or more, or major surgery requiring general or regional anesthesia within the previous 12 weeks, localized tenderness along distribution of deep venous system, entire leg swelling, calf swelling more than 3 centimeter compared with asymptomatic one, pitting edema confined to the symptomatic leg, collateral superficial veins, and previous documented DVT. طبعا it's not necessary to know all this, really not necessary, but at least you should know that this patient has high score, like our patient. Our patient has high score because she has it's clear calf swelling more than 3 centimeter if you compare it. She have also this patient also she has traveling or not travel for, traveling long travel before, but she has no active cancer. And you can also the last one minus 2 point if there's alternative diagnosis at least as likely as DVT. So
Okay.
when we should investigate the patient, how many points we need to
If well score is more than 2, we will
yeah,
investigate the patient.
not more, 2 points or more, 2 points
Okay.
or more, so DVT will be likely. 1 point or less, so DVT unlikely. So if DVT likely, 2 points or more, here I will arrange ultrasound Doppler for the leg. If ultrasound is positive, what I will do?
If ultrasound is
Positive.
ultrasound is positive, is highly suspicious of DVT, will start on anticoagulants.
No, DVT
CTPA.
ultrasound positive, خلاص, this DVT.
Yeah.
So 2 points or more, I will do ultrasound. If ultrasound positive, treat. If
Yeah.
ultrasound negative, what I will do?
You can go for CTPA.
For
Sorry.
for what?
If ultrasound is negative, then probably it should be negative then.
No. If now we have
D-dimer.
D-dimer. So D-dimer.
Okay.
So now if D-dimer negative, what I will do?
If still high suspicious, then we can go for CTPA.
No. Why is this is for pulmonary embolism, doctor. Now we are in DVT.
Okay.
So the dimer negative here, DVT is not likely. Consider other diagnosis.
Okay.
The dimer positive, treat and repeat ultrasound after 1 week.
Okay.
طيب, now we'll go to if the patient has a score 1 point or less. 1 point or less. So DVT unlikely. What I should do?
Unlikely DVT.
The score 1 point.
Yeah. I think we should follow up the patient.
Also, I should do
D-dimer.
D-dimer. Here, don't go to the ultrasound, go to the dimer. If the
Okay.
dimer If dimer negative, so DVT unlikely. But
Okay.
if the dimer positive, here I should arrange for ultrasound.
Okay.
Okay, so this is
Okay.
very important because sometimes the score will be very low. There's one scenario came before in the exam that this patient has trauma in her leg while she is doing sport. She has trauma in her legs and she has a swelling. After that, she told that this swelling improved, but I still feel pain in my leg. And this patient was active, not have any restriction of the movements. So the score was very low in this patient, and she has no risk for DVT. So the score was very low. So here you should tell the examiner that this first I will arrange the dimer before to arrange ultrasound. We know that in
Okay.
Western countries you cannot jump into the more cost or more invasive investigation unless to do initial investigation. Yes, in our countries, usually we arrange ultrasound for all people, but here there's guidelines. You cannot jumping directly to the second step. Okay, what other investigation now to rule out underlying? Young lady, young female lady has
Uh,
a family history also for clots. What investigation you will do for?
I would like to rule out any autoimmune conditions.
So I should do, what you should do?
I would like to do an ANA profile,
Yeah, NA for
and
example.
for if the patient is having previous history of abortions, I would like to rule out antiphospholipid antibody syndrome,
So I will do antiphospholipid and anticardiolipine antibodies.
antibodies,
Yeah.
and
What about PTT in
P-
antiphospholipid?
PTT will be increased.
Yes, will be prolonged in about up to it's mentioned up to 45% of patients with antiphospholipid. PTT will be prolonged. Also, what you will request for
And I would also
protein C, protein S,
protein,
Protein T.
protein C, protein A, yeah.
antithrombin 3, lupus anticoagulant, leading factor V mutation. This is very common cause of, and there is nowadays one study, there is study now, a broad study, mentioned that really all patients, all high percentage of people that develop DVT, even if provoked DVT, they have underlying leading factor V mutations. Really, this is a big study.
Okay.
That yeah. So for this reason, it's a request for all people. But this evaluation, this is protein C, protein S, antithrombin 3. When you will do it?
When there is an family history, any family history?
No, I mean at the time after DVT. I mean, if the patient you start anticoagulant, so it's better to delay it after to treat the patient. Why? Because this is can affect with anticoagulant.
Okay.
My question now, this is also important question, ready. So for this reason, I ask you during the case. Can patient with proximal DVT manage as outpatient?
Yes.
What indication?
Yeah,
Or
because
what the exclusion criteria?
if the patient is not having any significant medical history,
Yes.
and if the well score is less than 2, but still has a suspicion of DVT.
Where's the score? No, not related to this.
Okay.
So this is important questions. I will tell you why. Because this is can be asked by examiner first, and also you should manage the patient concern when the patient tell you I should stay in hospital. So for two reasons you should know the answer of these questions. So exclusion criteria, to manage patient as outpatient, suspected or proven PE. If you suspect or confirm BE, so this is you should not discharge the patient. Significant cardiovascular or pulmonary comorbidities. Patient has other disease like significant pulmonary disease like COPD or other. Iliofemoral DVT. Okay.
Okay.
If the patient has family or inherited disorders of coagulation like antithrombin 3 deficiency, prothrombin, 2020-10A, protein C deficiency. This should be admitted in hospital. Familial bleeding disorder, pregnancy better to admit the patient. Morbid obesity, renal failure, creatinine more than 2 milligram. There are other indications also, like patient homeless, patients has no living in far area, has no contact telephone, like this, and or if the patient resistant to outpatient therapy. So the indication, the most important contraindication, if the patient has suspected or proven PE, have significant cardiovascular or pulmonary comorbidities, has iliofemoral DVT, have family history or personal history of thrombotic disease like antithrombin 3 deficiency, protein C, protein S, and pregnancy and renal failure. So last question, doctor. Well, you see, I'm concentrating here about the questions about knowledge. Why? Because really these important questions, and we know that there are marks for knowledge in the basis exam. My question for you, when you can recommend patient to move the limbs after DVT?
After DVT, I think maybe 1 week.
Okay. Actually, we know that before that we advise the patient to don't move the legs. If you remember, I think before or 2 years, the all recommendation that don't encourage patient to move the legs affected with thrombosis. Nowadays, there's some change. According to up to date, it's mentioned early ambulation is safe in patient with acute DVT and should encourage as soon as possible according to this update after you start anticoagulation.
Okay.
So your answer should be encourage the patient, but after start anticoagulant.
Okay.
Okay. Thank you, Dr. Ampati. Thank you very much.
Thank you.
So for DVT, for leg swelling, leg swelling, common case in the exam. And yes, Dr. Ampati, I remember something. When you measure the difference between the legs, this is very important because be sure that the examiner observe you where you put the measure bell. So where you put it, where you measure exactly? So I ask this question.
Mid calf.
There's,
10 centimeter below tuberosity.
This is very important. And be sure if you don't do this, the examiner will be very angry from you.
Okay.
And they will consider you that unsafe doctor. But because this is the exact place to measure the difference between both legs. So 10 centimeter. Yes,
below
tell me,
the
doctor.
10 centimeter below the tibial tuberosity.
Yeah, this is an important answer, very important answer. So how can approach patient with leg swelling? Unilateral leg swelling. First of all, as we know in station 5, you should confirm the patient identity by his name and by his age. Then you should ask the patient, take permission from the patient, not only to talk about his health condition and examine you. Dr. Ampati, you told me only that I would to talk with you about your health condition. Not enough. Here you are in station 5, you will touch the patient. So tell the patient, we are here to discuss about your health condition and examine you. Is it okay for you? Yes, doctor, is it okay? So here you can tell him that it come to my knowledge that you have swelling in your legs. Show me here, I advise you the first of all to see the swelling. Why the important here to see the swelling at the beginning? Maybe this patient has something else other than DVT. Maybe the patient has Picker cyst. It's really will give you sometimes the patient will tell you I have leg swelling, but when you see that this swelling extend from to knee to the pillow, so maybe Pickers. And really there's other also. Many times in the scenario outside, the patient has leg swelling. It's either leg swelling or ankle swelling, and the patient maybe has Charcot joint, neuropathic joint. So very important, first of all, ask the patient to show you. Please show me your leg. When you see a leg like this, our patient, so now you know that this patient most likely has DVT. So tell me in more details about this problem. So here the patient will tell you what happened what happened with him. Now, for any swelling, you should ask about onset. Will it start? It comes suddenly or gradually? About the course, does it increase or decrease or same? About the duration, since how long? About previous attack, very critical here to ask about previous attack, because if the patient has recurrent DVT, so also you can change your differential diagnosis and management plan. Not only differential diagnosis, also the management plan will be changed if the patient has recurrent DVT. So you should ask about previous attack, don't forget. Does it affect one side or both sides? This is very important. Maybe the patient has asymmetric, but it affects both sides. And then how far the swelling extend? How far the swelling extend? Ankle versus calf versus whole leg, including the thigh. You should ask about associated symptoms: pain, swelling, increased temperature of the leg, change in the color or redness of the leg. So this is should also ask. Then you should ask about any history of a trauma. Maybe this is trauma. It is very important to ask the patient about any history of trauma, very critical also. There's marks. The examiner put the marks to ask this question. Then you should ask here, second important task for you, to know if the patient has pulmonary embolism or not. Very critical. If you forget to ask about pulmonary embolism symptoms, really be sure that you will fail in this case totally. He will consider you unsafe doctor. If you forget to ask about pulmonary embolism, you will fail in this case. He will not give you any marks. Be sure, really. If you do everything very well. Why? Because here, pulmonary embolism, if you don't ask about pulmonary embolism, so you are unsafe doctor. You should repeat the examination, or examination. So very critical. Don't forget, please. So here you should ask about PE symptoms, not only chest pain and shortness of breath. Really, be sure. Also, you should ask about palpitation, because we know that the early signs or early symptoms for patient with PE is palpitation rather than to have shortness of breath or chest pain. So very important to ask about chest pain, shortness of breath, palpitation, cough up blood. Not phlegm. Here, it's not important to ask about phlegm. You should ask about cough up blood only. Because we have no more time to ask in detail, so not necessary to ask all respiratory symptoms. Then you should ask the patient also if he has joints pain, especially knee pain. Why? To rule out rheumatoid arthritis, osteoarthritis, and in the case of Becker's cyst. After that, your task, the important task here, to rule out underlying cause. So what's my task? First of all, to confirm that this DVT, it's not anything else. To rule out pulmonary embolism, then I should know why this patient has DVT. Why this patient has DVT? First of all, if she's female, I should ask, because the most common cause in females, antiphospholipid antibody syndrome. So I should ask here about any previous clots, any miscarriages or abortions. And if she tells yes, doctor, I have abortion, I should ask her in which trimester. It's very important also. Let the examiner be happy from you. Let him know that you know what you are asking. And family history. Behçet disease, very easy to ask about Behçet disease. If the patient has painful sores, affect mouth and genital area. And also we know, if the patient tell you, yes, doctor, I have, so you are in Behçet disease. Here, you should rule out other complication. I mean, if you get any diagnosis, you should ask the patient about the other complication. I mean, if the patient tell you, yes, doctor, I have painful sores, affect my mouth and my genital area. So here you should ask about the eye symptoms to rule out panuveitis that usually common in the patient with Behçet disease. Paroxysmal nocturnal hemoglobinuria, very easy questions. Do you have any change in the water work, especially upon awakening? We know that most likely patients with paroxysmal nocturnal hemoglobinuria have changed their water work upon awakening, and over the day will be more clear. Other causes, and this came before in the exam, polycythemia. Polycythemia, ask patient if he suffer headache, blurred vision, and itching after hot shower. This is the general symptoms, but we have other symptoms like fatigue, like change weight, but most likely polycythemia, only enough to ask about blurred vision and headache and itching after hot shower. Inflammatory bowel disease, very important to rule out inflammatory bowel disease. Only one question or two questions. Do you have any change in your bowel habits? Do you have any bloody motion? Thrombophilia, only this I should ask the patient if he has any family history of a clot. If I find the patient only has family history of a clot but no other causes, so can I put in my mind this can be protein C, protein S. I tell the examiner most likely this patient has thrombophilia due to, because this is need lab test to confirm. So you cannot tell him that she has protein C or protein S or antithrombin 3. But if the patient has only family history of a clot and he has no other causes, so you can tell him that most likely this patient has thrombophilia like protein C deficiency, protein S. And last point, recent surgery. You should ask patient about recent surgery. Cancer. Last point, female history. Female history in any lady, critical. If you forget to ask about female history, so you will lose a lot. Because we know that the most common causes of DVT or other VT also, postpartum and pregnancy itself and OCP. So very important and very critical to ask about OCP, pregnancy and postpartum, and also long travel and immobilization. Last point I will tell you that about Becker cyst. Many candidates in the exam can sometimes find difficulties to recognize between Becker cyst, especially if large. You see this picture. I have this picture. You see sometimes really the one can confuse that this is Becker cyst or this is DVT. So it's very important, as I told you, to first of all tell the patient, show me your leg. Then here, this patient, most likely this patient with Becker cyst, they have pain, joint pain, and will be the cyst in the popliteal fossa, rather than to be and extend down to the leg, rather than to like DVT. DVT usually will start from lower parts and extend up. Okay, now, how can the last thing, how can examine the patient now? I will start, tell the examiner, I will see observation chart. Here, not enough to put your finger on the pulse. Yes, you should do. But tell the examiner, I should see observation chart. I should know how much the saturation. I should know blood pressure. I should know if the patient is feverish or not feverish. This is very important. So, first of all, check the pulse, and on the same time, tell the examiner, I want to see observation chart to see the patient saturation. This is very important. Okay? After that, you can examine the hands to see if the patient has any clues for underlying rheumatoid disease by inspection. This is why you are checking the pulse. Then here you should go to see if the patient has also evidence of anemia. For all patients in basis exam, you should see here the patient's eyes. Then you can go to see if the patient has any sores in his mouth. Okay? And then you can go to the legs. Here, better to go to the legs before to go to the chest. Why? Because here the patient in history has no any signs of or symptoms of pulmonary embolism. So better to go to the lower limbs. If you have time, then you can go back to the chest. So how can I examine the patient now? First of all, I will go to the legs. I will see if there is any distended superficial veins, if there is any bruising or injury, if there is any erythema consistent with cellulitis. I will see also if there is any ulcers. Okay? So first of all, inspection of this swelling. Then I will do palpation. Palpation. I will see if there is any firm or pitting edema. Okay? Then I will see the temperature. I will compare both legs. I will see if the patient has increased temperature of the underlying overlying skin. And then I will determine whether the tenderness is over the superficial veins or diffuse or localized. and I will see if the patient has, I will check pulse, peripheral pulse, very important here also to be checked. So I will check the pulse, and then I can go to the examine the chest if I have time, and also can examine the abdomen to exclude any abdominal or pelvic mass. But here, first of all, you should go to the legs, because if you the time finished, so you are guaranteed that you finish the examine the important part in the case. And observation chart, don't forget to ask the examiner, I will see observation chart. Any question, please?
Excuse me, sir. During examination, is it important to examine the toes, the webs of the toes?
Yeah, really, if you have suspicion that this patient has cellulitis, yes, it's better to examine also to see if there's any tinea pedis. Yes, if you have suspicion that this can be cellulitis, or if the patient has diabetes, or patient has cancer, so better to examine, yes.
Second question, sir. For pressing of the cough, before they were saying that it is not important, it's contraindicated to press the cough, so that there is a chance that you may disclose this clot. Is it still no?
Yes,
This is
doctor.
a practice, or
Yes, doctor.
changed?
Yes, doctor. Yes, doctor. It's very important. Now, this patient has swelling, you see, in the total leg. Okay. Now, only I am pressing the skin from outside, very gentle. I will see if the patient has beating edema or not beating edema. Not a contraindication to press the skin.
Yeah.
This
Okay.
you will not move the clot by your only if you press gently on the. You will not move the. As I told you now.
For checking tenderness, how
Yeah.
will
Yeah, but here it's better in the exam situation. Yes, in the exam situation, you see, I didn't tell you to move the legs here. Don't move the legs. Don't only you can press your, you put your fingers. Ask the patient if you have any pain. Tell him I will be very gentle with you. Only put your fingers, 2 fingers, on the frontal surface of the leg, and see if the patient has pitting edema or not pitting edema. I will tell you that I have tenderness. And here by questions, better here to don't move, to don't examine, and in more deeps.
Hassan, is a long travel history alone is a cause?
Yes, as I told you, it's a cause, but really there's now a big study told that really all patients that have a provoking DVT, they find that they have also the underlying cause like factor V leading mutation, and also this 2001 mutations. Really, this big study about this. But yes, it's risk factors. But here you should ask patient, very important also, if the patient tell you, yes, doctor, I returned back 1 week from long haul travel. You see, you should ask him also here, do you move your legs while you are on flight? Do you move your legs? Do you walk during the flight? Also, you should ask him to be sure that the patient has restriction of movement for a long time. But here, even that, you should rule out underlying cause. You should not depend only travel. So in my case here, I told you travel, but really this is not the one cause. And be sure in the exam situation, the travel will not be the only cause for DVT. Always you should look for the other cause in the exam situation. Travel will not be alone. Other thing else should be present also.
Dr. Hassan, you told that there is some indications to admit the patient. If the patient is suspected or confirmed pulmonary embolism, or the patient is pregnant, or the patient has family history. But we don't know about the family history, because we know about the family history, but we don't know that this is confirmed familial cause.
Yeah.
So if we ask only about the family history, if the family history is positive, so we should admit, right?
Yeah, really, it's written here. This is guidelines in up to date. It's clearly that if there is family history, of clot, so better to admit the patient. Yes.
What is the idea, doctor, from this?
Really, the idea first of all to investigate the patient more. This is very important. And also, if there is family history, that there's the risk to develop the patient to develop the other clots can be more. because there maybe there's some disease provoke this clot, Dr. Sayed. You understand this idea? But really this is what's written in guidelines. But if you would explanation from me, this is my explanation, that if the patient has family history, so they have more risk to develop other clots in the other body now, because we don't know now why this patient has a clot. But if the patient only she has now postpartum DVT, postpartum, okay, the patient now delivered, and she has no family history and she has nothing, so most likely this because delivered she developed DVT. That reason, yes, you can discharge him. It's safe for her to discharge her.
Okay, and regarding treatment, the novel anticoagulant are the best option for this patient. Am I right?
Low molecular weight heparin, should be started first of all.
No,
And
novel, I means NOx.
yes. It's now, you know, that there's now also approved that novels can be used in the patient with DVT also. Yes, you are right.
Hassan,
Doctor,
for
what
the
about
duration,
Hoffman
if the
sign?
patient is
About
Hoffman sign.
Hoffman sign? For what, Doctor?
Yeah, just when you dorsiflex the foot, there is pain in the cuff.
No need to do it. No need, because this is what's the benefit to do it, Doctor?
For confirmation of diagnosis.
Really,
That was before a test
really,
by the name of Hassan.
in all new references I read up to date. I read many books now. Nobody mentioned that to do like this. Only nowadays to do inspection, to do if there's anything edema or no.
Dr. Hassan, it is obsolete. Yeah, you are right. It is obsolete. This Hoffman sign.
Especially it's
Actually,
Hassan,
regarding this,
for the duration.
Observations are generally mentioned in the scenario given outside. Do we still need to ask the observation again in the room?
What, Doctor, repeat the question, please. This is important.
The
question.
observations like temperature, BP,
Yeah.
pulse, and all are being given in the scenario.
Yeah.
Right.
No need to ask. Tell him that according to the examiner, according to observation chart given outside, that saturation like this, pulse rate like this, and temperature like this. Yes, no need. It's enough.
Dr. Hassan, for the duration, if the patient is pregnant and she delivered, for how long I need to continue?
Very, very nice questions. Really. For first episodes of deep DVT, patient should be treated 3 to 6 months. Okay. If the patient has recurrent episodes, so should be treated for 1 year. But we know if the patient has underlying cause like antiphospholipid antibody syndrome or like, maybe the patient, according to many studies, need lifelong therapy. So first episodes 3 to 6 months, but recurrent episodes should be treated for 1 year.
What about the duration of 3 months? Not 3 months?
3 to 6 months. 3 to 6 months. I mentioned that first episodes of deep venous thrombosis, according to up to date, 3 to 6 months. This is really in regard to the doctor, treating doctor. So you have the options to treat from 3 to 6 months.
What is the determining factor?
Recurrent DVT, they are saying that you have to continue throughout.
No. I mean, Doctor, I will tell you something. If the patient has recurrent DVT, postpartum DVT, okay, but you don't find any underlying cause like protein C or protein C deficiency or antithrombin or anything else, so most likely this is provoked DVT, so you can treat for 1 year here. But if you have underlying cause, will change. Maybe we'll need lifelong therapy. Yes, the question, this is for 3 to 6 months. How can decide 3 to 6 months? Really, this is nobody can give you clues, very specific clues how can manage. Like me, for me, in a patient with cerebral venous thrombosis. In cerebral thrombosis, the recommended time for treatment 6 to 9 months. Really, sometimes this is written back to the how much the patient improve. I will tell you something, Dr. Sayed. I think Dr. Sayed asked me this question. Huh?
Yes.
Yeah, I will tell you how. For me, for patient with cerebral venous thrombosis, I will observe the patient. If I feel the patient has no more headache, no papilledema, no any symptoms related to cerebral venous thrombosis, and after 6 months therapy, most likely I will stop it. But if I feel when examine the patient still has some papilledema or mild, not improved, sometimes still has headache like this, so I will extend the therapy for 9 months. Also for DVT, really I saw many consultant internal medicine. they treat patient only for 3 months, but some other consultants really extend 4 months or 5 months according how much the patient doing over this period. So, but it's written clearly the treatment for provoked DVT from 3 to 6 months. So you are the consultant that you treat the patient. You can sometimes decide this according to how much the patient improve, how much the patient sometimes complains. You see, sometimes the patient really stop medication for 1 week and then return back, and then you see, we have many cases like this. The patient stop treatment 1 week and then return back for you and then resume. So this patient better to extend the duration sometimes to be sure that he has no more clot.
Dr. Hassan,
According to the progression of the condition.
I have a question, Dr. Hassan.
Yes, doctor.
Yes. If we have a patient who has a hemorrhagic stroke and he develops DVT, so how do we treat him?
Balance between benefit risk ratio.
So how should we manage?
Yeah, this is usually you know that we have something called umbrella. You know it, doctor?
No, I don't know it. No.
Yeah, the patient usually if the patient has DVT, developed DVT while she has brain hemorrhage, so better in this case to put that. This is what's called this can be the
inferior vena cava.
Anterior vena cava umbrella. Yes, this is one. So
you mean vena cava filters? I mean.
Yeah, this is better because here our aim only to prevent PE, pulmonary embolism, to prevent the clots go up.
So is there a role of novel anticoagulants in this scenario? Is there a role of novel anticoagulants in this scenario? Hemorrhagic stroke with DVT. Is there a role of novel anticoagulants in this scenario, or no? We need to
same thing, doctor. Same thing. Because both novel anticoagulant also and warfarin can increase the risk of brain hemorrhage. So same efficacy.
No, if the patient develops cerebral hemorrhage, so why he developed DVT? Because these are two opposite things, hemorrhhage and DVT. How can he develop
because of the paralysis? Because they have important because he will be, for instance, he has a hemiplegia, he has a paralysis, so that can lead to DVT.
Yeah,
but this is very rare. I think this is very rare. I have not seen and I have not treated.
I have a question.
It's quite common. It's quite common. A patient with stroke, he can have it's very common. It's very common. A patient who's having a paralysis, he's a risk factor for DVT, so he can develop it's very common.
So please, you can go to the second case. We'll go to the second case, please.
Only sir, 1 minute. I just want to know about the proximal DVT. You told that we can discharge the patient. On what basis? In general question from the examiner, acral DVT as compared to the proximal DVT. In the proximal DVT, like femoral venous thrombosis, what we have to answer that we will discharge the patient.
I told you, doctor. I told you that if the patient has iliofemoral DVT, so you should admit the patient. Should be excluded. Iliofemoral DVT should be admitted. This one exclusion criteria. Second case, who will take this case? Second case.
If you allow me,
Dr. Sayed?
Yes.
I will give you. Because since long time you don't case with me. Sorry, not this. 1 minute, Dr. Sayed, I will open it, please. Two minutes, Dr. Sayed.
Okay, doctor.
Start, please, Dr. Sayed.
1 minute more, doctor, please.
1 minute. Okay. Yes, Dr. Said, are you ready? Dr. Sayed, are you ready? In exam, you have only 2 minutes.
Yes,
You cannot,
doctor.
yeah, please. You
Okay.
cannot find more than 2 minutes exam. Yes, please
Okay.
start.
Okay. Good evening.
Good evening.
I am Dr. Gendi, senior house officer in the medical outpatient clinic.
Yes,
I
Doctor.
want to confirm that you are Mr. Roland,
Yeah,
28
I'm
years
Roland,
old.
Doctor. Yes, Doctor, I'm Roland.
Nice to see you.
Thank you, Doctor.
Mr. Roland, it came to my knowledge that you have a medical problem as mentioned by your GP, that
Yes.
you have the problem of recurrent infection.
Yeah, Doctor.
Can you give me more information about this, please?
Yes, really, Doctor. I had been suffering recurrent chest infection and also ear infection over the last year. Last time was 3 weeks before when I came to emergency department and they give me antibiotics for a few days.
Okay. Since 1 year you are starting this problem, Mr. Roland.
Yes.
You give me how did it start gradual or
Recurrent, Doctor. Really, every time I have
recurrent?
a cough, sometimes flame and raised body temperature, and they told me that this chest infection and one time ear infection like this.
Okay. Then I want to ask you, you have any past history of any important disease?
No, Doctor.
You have
I was
diabetes, hypertension.
no, Doctor. I was fit.
Okay. Tell me please about show me please your medication list.
I don't take any medication, Doctor. Now.
Okay. Any lumps and bumps in your body?
No.
Do you have any travel or skin rash? Travel
No,
outside?
Doctor. No, I'm not
Skin
traveling.
rash?
No skin rash, Doctor.
Then any surgical operation?
Yes, Doctor. I have surgery before.
What type of surgery?
Really, Doctor, I have road accident 3 years before, and they did surgery on my tummy.
Yes. What did they do? You have any idea?
Yeah, Doctor. They told that remove this what's called spleen before that was affected.
Okay. Then after removal of your spleen, Mr. Roland, did you receive vaccination
Yes,
given
Doctor.
to you?
Really, they gave me vaccines when I did surgery, but since that time I didn't take it. Really, Doctor.
You didn't take more
Yeah,
vaccine or?
yeah. Not only one time. They told me that I should take it yearly and every 2 years, and they told me that I should take also medication. But really, Doctor, I stopped to take it since more than 1 year.
Okay, so you missed, you have missed the
Really,
vaccination
Doctor,
dose.
I feel that there's no benefit because I didn't get anything when I am taking it before.
Okay, Mr. Roland. Then I want to ask you, do you smoke, Mr. Roland?
Yes, Doctor, I'm smoking.
Okay. What about alcohol?
I'm drinking, Doctor, also.
How much you drink, Mr.?
5 to 6 units, Doctor, weekly.
Okay. What about the weekend?
Only including weekend, Doctor.
Okay. Yeah, you told me that you smoke, Mr. Roland.
Yeah.
So I want to advise you, Mr. Roland, and all patients that smoking is harmful for your health, and I advise you to stop smoking. And if
Thank you,
you
Doctor.
don't mind, I can refer you to the smoking cessation clinic to help you to
Thank you, Doctor.
smoke
Appreciate.
those. Okay. How much is your condition affects your life, work, and
Really, Doctor, it affects me as I told you because I have this recurrent infection and I should be off from my job when I have this infection. So really, it affects me, Doctor.
Okay, so I shall refer you to this work
occupational health worker,
occupational health officer to help you, Mr.
Thank you, doctor.
Okay, how much it affects your life?
As I told you this, doctor, when I have this infection, it affects me.
So also I can refer you to the social worker for more help from this side.
Thank you, doctor.
Okay, you have any family history of similar condition, Mr. Roland?
No, doctor, nothing.
Okay, can I examine you, Mr. Roland?
Yeah, please, doctor. What you will examine, Dr. Sayed, now?
I'll examine first. I want to examine temperature.
Yeah.
How much temperature?
No, normal temperature. No fever now.
Okay, I want to examine the face for any. Just examine the tongue for. Sorry, I examine the finger for any clubbing.
Very nice. Why? Why for?
For corona, maybe bronchitis infection. Like
very nice. Recurrent chest infection sometimes can cause bronchitis. You are very good. Yes. So I will examine the hands. I will inspect the hands. Very nice to see if there is any evidence of anemia, if there is any evidence of also bronchitis, because this patient has high risk for bronchitis. Yes. What else?
I want to examine the tongue for any cyanosis or respiratory failure.
Yes, normal examination. Yes.
Okay, examine other part of the skin for any pustules or boils or like this.
Nice.
Then I'll go down to examine the chest.
Normal examination of chest. Normal examination of the chest. Yes. At least you should auscultate the chest. Yes, it's normal examination.
Okay. Then go down to examine the abdomen for.
This is the abdomen.
Sorry.
This is the abdomen.
Yes.
Yes.
Yes, there is oblique left hypochondrial wound. The effect of the previous exploration and removal.
1 minute.
Okay. Then, what is your concern, Mr. Roland?
Doctor, why do I have these recurrent infections?
Okay, I appreciate your question, Mr. Roland. That you have been splenectomized. Sorry, your spleen has been removed because of injury in the RTA, and spleen is an important part in your defense in your body defense mechanism against bugs. Yeah. So now the bugs find your body without proper resistance. That it's easy for the bugs to flourish in your body because the cell.
Thank you, Dr. Said. Dr. Said, what's the meaning of RTA?
Road traffic accident.
So you should not tell the patient RTA. The examiner will be angry and the patient will be angry. What's the meaning of RTA? RTA, this is can use only with your colleagues in hospital. You cannot use in the examination. Dr. Said, really you are great, really, but you missed something important also. It's not enough. I told you before for all. When you get the diagnosis, so this not mean that you finish the scenario. Yes, you get the diagnosis very well, but this not mean that I finish the scenario. Why don't ask about HIV risk, doctor?
I asked about travel and
only travel, not enough. What about the sexual history? What about the breathing, tattoo, blood transfusion? Very critical in this scenario to ask about HIV. Very important. Very important. Also very important. So my question for you now: what are differential diagnoses from outside? How do you prepare your case outside?
This immune deficiency, either congenital or acquired. In this age, it is acquired. So we ask about acquired condition.
But like maybe this patient has recurrent chest infection since childhood. Maybe now he is 25 years, but 28 years he's this man. But maybe he tell you inside that I have a recurrent chest infection, doctor, since childhood, since I was child. So you should put also cystic fibrosis in your mind.
Cystic fibrosis, yes.
You should put in your mind. Outside, you should prepare yourself that this can be cystic fibrosis. Also, the other diagnosis, if you remember, we discussed one case before, if you remember it, about primary immunodeficiency disorder, common variable immunodeficiency disorder. You remember it before? We discussed it before, I think about 3 months before. Common variable immunodeficiency disorder. How can the patient with common variable immunodeficiency disorder present?
Present with recurrent infection since childhood.
Not childhood, no. Not childhood. Can be present from teenagers or 20s. So, common variable immunodeficiency disorder, and this is very common in the exam situation. Usually the symptoms will start at the age of 20. Okay? And the patient should, what he has also else besides to the recurrent chest infection?
Allah, I don't remember.
Yeah, autoimmune disease and
yes.
and maybe will develop lymphoproliferative disease. So autoimmune disease, very important. This is the key that can differentiate common variable immunodeficiency disorder that the patient has autoimmune disease like rheumatoid arthritis, like celiac, like inflammatory bowel disease, like vitiligo, anything, pernicious anemia. So this is very important, and this is common in the exam situation. What else, Dr. Sayed? You mentioned for me now cystic fibrosis. You mentioned for me primary immunodeficiency disorder. What else?
After that, acquired.
What's the cause of acquired?
The most common now HIV.
What else?
As this case is splenectomy.
Yeah.
Or organ immune suppression, organ transplantation.
Yeah, or immunosuppressant medications, very important. And this is also can come in the exam that patient receive any immunosuppressant medication that can decrease the immunity. So, very nice, Dr. Sayed, to put splenectomy in your mind. Because if you forget to ask about surgical history, you will not get the diagnosis. The surrogate will not tell you that I have surgery unless you ask him clearly. If you don't ask him, if you ask him from here up until 1 week further, what the medical illness you have, he will tell you I have no medical illness. You should ask him about surgery. He will tell you, yes, doctor, I have this abdominal or tummy surgery because car accident. Yes. So, Doctor said, I will only really you are great in this case. You will get, really, if you are in exam now, you will get more marks. But my question here for you, or my guide, I will guide you about something. When you start the case, you introduce yourself, confirm the patient identity. Here you should tell him at least that we are here to discuss your health condition and examine you. Is it okay for you? Very fast. Why? Because you should take permission. Any patient, before to touch him, you should take permission. So here, one point, I want to talk about your health condition and examine you. Is it okay for you? Yes, doctor. Okay, now start. Okay, start your history. So, you ask me about this chest infection. I told you, yes, I have chest infection. This is, here your question should be, when was last infection? You should ask him when was last infection to know that maybe he's now has infection now. This will guide you in your exam. Maybe the patient has something now. Okay? And then you should ask him about fever now. Maybe the patient now has infection. So you should ask him, because he told you that I have recurrent chest infection and ear infection. You should ask him about fever and mumps and lumps. Weight. You don't ask me about weight. Weight change here important, because we know that HIV patient or cancer patient maybe has weight change. Vaccination, very nice. You ask me about vaccination, very important here. And also you don't ask me about illicit drug. Young patient with recurrent infection. It's important to ask about recreational drug, Dr. Sayed.
Okay.
Yeah, it's important.
Of course. Yes.
Yeah. So what management, what you will give the patient? Now, examiner questions. What the management?
Actually, resume the schedule of vaccination.
Yeah. Yes, right.
And and the treatment of early treatment of in any infection, and give I think prophylactic penicillin like against pneumococci or like this.
Yeah. So vaccinations, this is very important. Vaccination. What usually vaccination you will give for this man?
You give against pneumococci
Yes.
and the Haemophilus influenza, I think.
Yeah, and also pneumococcal. So meningococcal, pneumococcal, and annual influenza vaccination, and also HIV. Okay. What about penicillin?
HIV vaccination, doctor?
No, not Haemophilus. HIP. HIP.
Yeah. HIV, sorry.
Yeah. What antibiotic you will give him?
Long-acting penicillin.
Penicillin. So here it's written clearly that clear guidelines don't exist for how long antibiotic prophylaxis should be continued. It's written that should be continued at least 2 years. Okay, at least 2 years. Okay, and what else if the patient were to travel? What you will advise him?
To travel, to take the corresponding vaccination according to the area of.
Yeah, especially if he's traveling to malaria endemic area.
Yes.
So also the patient should carry information card. This type of patient should carry information card. It's very important. What are most common organisms can cause infection in patient with splenectomy? This is very important question in exam.
This encapsulated
very nice, Dr. Said. Encapsulated bacteria, very nice.
Bacteria, yes.
You see here, really, it's not necessary to mention all, but at least you should tell the examiner to know, to show the examiner that really you know everything. So encapsulated bacteria, this is the important answer. Whose patient has more risk for infection after splenectomy?
Sorry, again, doctor?
Whose patient they have more risk for infection after splenectomy? You see, we have many patients have splenectomy and sometimes not compliance to vaccines and to antibiotics, but have no infection. Whose patient more risky for infection after splenectomy? And this should should be concerned about giving him vaccines and antibiotics.
According to the age, I think, huh?
Yeah, also age and else. What else?
I think comorbidity.
Yeah, the patient with underlying hematological disorder, like malignancy, like thalassemia. This is very important. Okay.
Okay.
So patient with underlying hematological disorder, like thalassemia, like lymphoreticulaar malignancy. So how do you feel in yourself now, Dr. Sayed, after this case?
Better, alhamdulillah.
Do you suspect this case? Do you suspect that appear in the exam?
Actually, doctor, I suspect anything.
This case came, this diet 1 2020, appear in one center in India. So this is a new case now in this diet. So very important case. Why I discuss this case with you? Because only to increase your awareness that this appear in the exam and you should ask about surgical history. For this reason, I discussed this case today. So thank you, Dr. Sayed. So I will only mention one point. I will mention one point. After that, I will receive question. In exam situation, recurrent chest infection, either in station 2 or in station 5, put in your mind, first of all, cystic fibrosis and Cartesian syndrome. So very important to examine the site of heart. 2, put common variable immunodeficiency disorder, and I told you that usually the patient has other autoimmune disease. But don't forget splenectomy. Don't forget splenectomy in station 5, very critical. HIV. Really, if you don't ask about HIV risk, if the patient young like our patient, so you will lose more marks. And as I told you before, malignancy. Maybe the patient has underlying malignancy. Also, this patient has more prone to get infections, and if he's taking immunosuppressant medication. Yes, doctor. Who will ask me now?
Me, Dr. Hassan, what is the duration of penicillin prophylaxis?
Yeah, penicillin until now there is no clear guidelines to tell you how long, but usually it's written for at least 2 years, and some doctors or some authors prefer to give lifelong. But now, yeah, there's no clear guidelines about this, but it's preferred up to 2 years after, at least 2 years after the splenectomy. You can tell the examiner like this, that there is no clear guidelines about this, but at least the patient should take it for 2 years after the surgery.
Excuse me, doctor, this extension of the time more than 2 years, are there any risk factors on the basis of which they are continue, or just there's no,
yeah, you are right. Yes. The most important thing is vaccination rather than antibiotics prophylaxis. The vaccination should be lifelong. This patient after splenectomy should be take vaccinations lifelong. But for antibiotics, it's mentioned like children. Like children, if the children has splenectomy, should be up to 16 years when they exceed 16 years. So there is no guidelines, no clear guidelines about duration of penicillin. But for vaccination, most important thing, vaccination. So this is the important management for patients with splenectomy, vaccinations.
Excuse me, doctor, my question was that they are telling at least 2 years. Yeah. If those people who are using it for more than 2 years, or they are advising to use this, are there any risk factor on the basis of which they are advising for the long-term use of the penicillins?
As I told you, doctor, it's written clearly, no clear guidelines, except for how long antibiotic prophylaxis should be continued.
Okay, thank you.
So you can look in the other books, but this is what's mentioned in the guidelines. Okay, thank you very much for your attendance.
Okay, and about prophylaxis after those 2 years, when there is surgery or dental
very nice, very nice. So for splenectomy, the most important, I will repeat this answer. The most important treatment, if the examiner tell you what that treatment, how can manage this patient, you tell him that vaccinations. Okay, this is first of all. For antibiotics, as I told you, no clear guidelines for how long, but at least 2 years after that. But really, I advise if the patient will get any surgery, yes, to take penicillin. If the patient will get any surgery, before the surgery, better to do even dental procedure. Why? Because this patient has high risk to develop infections. So this is also otherwise. But really, there's no guidelines about this issue. If anyone have any also idea, can share us in the group. Okay, thank you very much. I hope that today the cases was really very beneficial for you. And I think DVT very important. Please don't go to the examination without prepare DVT very well, because really, if you forget anything in DVT case, the examiner will be very unhappy, because this is common case in our real life, and also serious cases should be managed very well by senior house officer. So please, DVT, study it very well. Thank you very much for your attendance.
Thank you very much, doctor.
Thank you very much.
Thank you very much.